All right. Well, welcome everyone. Thank you for joining the CGM operationalization panel discussion today. We're really excited to have everybody here. We're awesome. We have our awesome panelists that we're so grateful for that are going to be speaking to you about some of the pre-submitted questions that you had sent in when you registered for today's meeting. And so we're hoping today will be a very robust conversation. There will be time at the end after we go through all the submitted questions to ask any questions that come up or that you did not have the opportunity to submit in advance. So without further ado, we can go ahead and get started. So our agenda for today will be to review a couple of the CGM resources that MCT2D has put together, talk about where you can find those and what they're used for, and then we'll go through and have a couple of panelists speak to each of the pre-submitted questions. There'll be a slide for each question so that you can refresh your memory as to what question is being answered. And then at the end, there'll be, like I said, time for live questions from all of the attendees here today. So for the MCT2D created tools, there's a few that I want to highlight here. Starting from the left, we have the Affording Your Type 2 Diabetes Care. It's a patient toolkit on insurance coverage and cost. There's a lot of information in this. It's really a worksheet that's meant for patients to be able to use as they call their insurance company. It does not just pertain to, oops, this is not advancing. Why is this not advancing? Hang on. Okay, I'm going to do it by mouse. My apologies. There is our agenda. And then here are our slides. All right, so as I was saying, on the left here, we have our patient toolkit. So we have a number of different things in here. And so the provider is able to check which item that they're hoping for their patient to call their insurance company and inquire about. So it includes things like the GLP-1 receptor agonists, the SGLT2 inhibitors, CGMs, including prompting questions, prompting the patient to ask questions that are specific, such as which of the CGMs is preferred for patients with my insurance, which of the GLP-1s and SGLT2s are preferred, what are my copays for the CGMs, and things like that, so that the patient can really be empowered to ask the questions that are needed for them to be able to get prescribed and covered for one of these devices or in certain other circumstances, medications. It also includes the definitions of different insurance terms that patients may not always be familiar with. In the middle, with one's name posted over it, apologies for that, we have the medication and CGM coverage by payer in Michigan. So this is a document that we update quarterly with the different coverage levels for the main payers in the state of Michigan for CGMs, and it includes a breakdown between pharmacy and the medical benefit or the DME side based on the different coverage levels. It includes the criteria, where there is some, and whether or not there's prior authorizations required. And like I say, that is updated quarterly. And then finally on the right, we have on-demand continuing medical education sessions. And so this was a pre-recorded session that was completed by Dr. Radhika Papasui, who is the incoming president of the ADA, last fall. And this has two sessions, two one-hour sessions with regards to background on CGM in type 2 diabetes and really operationalizing it in the clinic setting, as well as how to interpret reports, what is most clinically useful, how does CGM interact with making dietary and lifestyle interventions. It's a very great tool. It is a free CME resource. It is available on our website. We highly encourage anybody that's interested to go ahead and take that training. It is really great. So next, I'm going to introduce our panelists here. So we have 6 panelists with us today. We're very grateful for their attendance. So we have Nadia Anis, a pharmacist from HVPA, Juan Reyes, another PharmD from Olympia, Jessica Prokiv, I'm sorry, I can never pronounce your last name. Thank you. Yep. PharmD from Bronson, Susan Nason, care manager from Bronson, Shirley Cardinal, an RN case manager from Primary Care Partners, and Mary Wilson, a nurse practitioner from Metro Health. So we're very grateful to have them here to share their expertise with everyone regarding CGM workflows in the primary care practice. So without further ado, we can go ahead and get started. We do have the pleasure of having Dr. Kara Mizukami-Stout here, an endocrinologist from the University of Michigan, who is an expert in the field of CGM use. And she will be moderating our discussion today, introducing the questions and really helping to facilitate the discussion on each one of them. So we are very grateful to have her here with us today as well. So without further ado, Dr. Mizukami-Stead, I will turn it over to you to get us started on the first question here. We have defined who was comfortable speaking to each of these questions, so it should be pretty straightforward. Whoever would like to start speaking first is more than welcome to.
Okay, thanks, Jake. I really appreciate that introduction. So as you mentioned, I'm an adult endocrinologist at the University of Michigan. So I may chime in every now and then if I feel like there's any tidbits I could add. But let's go ahead and get started with some of the pre-submitted questions. So the first question is, what is the process for prior authorizations in your office? Do you have dedicated staff members who do these prior authorizations? And we have a few panelists who can hopefully help us out with this.
Hi, I'll speak to that. My name's Shirley. The process, well, let's just start with who's the dedicated staff member. It's me. I'm an RN case manager. I work in 2 doctors' offices, 2 days in Bridgeport for Dr. Jane Castillo, 2 days in Birch Run for Dr. Isa El-Sharif and Dr. Robert Grimshaw. I do it all. I get the order, I do the authorizations, education, all of that. So what our process basically is, honestly, doctor says, hey, I want this guy, or I identify this patient that I want on the CGM, and then I take it from there. I go ahead and we do a trial, usually either with our Dexcom G6 or the Freestyle Libre. We now have we have 2s and we also have 3s in our office. And after that, they like it. They come back again in 2 weeks. Doctor looks at the report, and from there on, I do the authorization when each insurance is different.
Okay, thank you. I appreciate that. We have a similar process here at the University of Michigan, and I was wondering if any of our other panelists have any other sort of system where there's multiple members of the team kind of working on it, or is it usually a single kind of like go-to person?
In my office, the MAs do the prior auths. And then if they hit a snag or they need more information or I need to appeal something, then I get involved.
It's the same at, this is another Bronson office. So if it's a prior authorization, then the medical assistants will initiate that. I think my experience with the CGMs hasn't been so much that they need prior authorizations that can easily get approved as much as just initiating the order. And I've been working on training my doctors on initiating the orders for these, but I think I've only done a couple prior authorizations for like switching patients from a Libre to a Dexcom, for example. And those I handled because it was already a little bit more complex than what the medical assistant was used to working on, like with writing an appeal and that kind of stuff.
Okay, what kind of training process do you have for some of these staff members, or is it really that different from some of the other workflows for insurance barriers for other types of devices or medications? As a follow-up question, if
do you mean for just like ordering the sensors themselves, or for training the patients?
Are there for training of the medical assistants who are in your office?
I wouldn't say there's any particular training that we do for the medical assistants for the prior authorizations, that they would follow the same kind of steps that they would for any other sort of medication that they might come across. I don't know if it's any different at your office, Susan.
They follow the same process as ordering traditional testing supplies. And then, yeah, I'm always available if they hit a snag. So.
Okay, that's great. And you said that in both of your systems, it sounds like there's one order set for clinicians to basically sign and say this patient is interested in a CGM, or I would like this patient to have a CGM. Is that a specific order set built within the EMR?
Yes, we have it set up in Epic.
Okay.
And it's very easy. Our problem is we just don't have enough staff for an MA to take that on. All of them are already working like 2 positions each, so for them to take on that prior auth, it doesn't happen easy even for myself to get prior auth sometimes. So So blessings to you guys that you have that staff that can do that. I appreciate it, and I'm jealous.
And in my office, we have such a large volume of continuous glucose monitor orders going out. There's no way that one person could handle that volume.
Yeah, and I would just add too, because for the office that I work in, it's a smaller office. We have 2 providers than myself. And so all of the prior auths get funneled to me for medications and for CGMs, because the MAs were just like struggling with everything that they were trying to do. And so we kind of changed the process a little bit. So I have some dedicated time set to make sure some of these things are smoother. And I would say for CGMs, I mean, I agree. A lot of it is just like understanding the criteria and having it up front before even like trying to send it. So understanding that piece has made this process a lot easier for me, because then I just make sure it's like upfront in my note, or, you know, in the doctor's note, or whoever is trying to do the order. And that kind of smooths the back and forth, which is where some of that time piece really happened in the beginning, where I would have like Medicare, for example, that would come back and say, oh, well, this wasn't in your note. And it's not that it wasn't in the note, they just couldn't find it the right way. So now I just make sure that, you know, in the assessment and plan, it is like bolded, it is bulleted, it is very clear, it's the wording that they're looking for. And that makes this process much smoother, at least from what I found.
Great. Thank you. I'm seeing some questions pop up in the chat in the Q&A. And I think what we'll do is we'll go ahead and go with the pre-submitted questions, and then we'll do the follow-up questions in the Q&A during our live session. So we can get through our pre-submitted questions first, okay? I think we had some great answers to that first question. Jake, do you want to guide us to the next question? All right, our next question, how do you navigate insurance coverage for CGM generally? I think a lot of you already spoke to this during the authorization process. I guess a follow-up question is, have you noticed any differences in insurance companies that require you to go through a DME versus a pharmacy? And can you speak to that process?
Sure, I can start with this. So going through DME always seems to take a little bit longer, because I have found that like finding the correct even place to send the prescription to in the first place takes a little bit of time. There are some really nice resources that I found, you know, of course, like on the MCT2D website, and then also like Freestyle or Abbott has, you know, some where they say like, okay, these are the ones that we work with. That process has gotten a little bit smoother. Again, just the more you do, the easier that is when you kind of find where those places need to get sent. There's usually a lot more back and forth, and it just tends to be a little bit harder when the prescription has to go to DME. I very recently found out, I found this out last week, that for Dexcom, even for Medicare, they're preferring that those prescriptions are going to Walgreens. The prior authorization on their end is still taking a lot of time, but that was new that I just found out. I don't know if anybody else has kind of seen that come through, but otherwise, when I'm able to, I try to send to a pharmacy, their local pharmacy first, and see what happens. Especially if I'm not sure if it'll get covered or not, I usually start there, just because the process seems to be a lot easier than trying to go through DME with the back and forth and faxes and things like that.
And I'd say that I usually do DME out the gate for anybody with Medicare. And I usually go on Parachute and use that for ordering. And I tend to use ADS, the Advanced Diabetes Supply Place, the most. They've got a lot of good support to come out through there, but there are some Medicare insurances that have to go somewhere else. Like if it's Blue Care Network, it has to go to JMB Medical, and that's always a pain, and they're not in Parachute. And then if it's a commercial payer, pretty much any commercial payer, I'll send to the local pharmacy. And any Medicaid, I tend to send most Medicaids to Healthy Living Pharmacy. But I have had some success with Advanced Diabetes Supply with Medicaid as well.
And in my office, we send everybody to the pharmacy first. The copay can be different at the pharmacy than through a DME for both Medicare and commercial. There are a couple Medicare Advantage plans that can get their supplies through through like a local pharmacy or a mail order pharmacy, and their copay is a little bit less if you do it that way. So we always try the pharmacy first, and if that fails, then we send to a durable medical equipment company. I use Parachute and ADS for Medicare. ADS has a patient assistance program. So if it's a Medicare patient and they can't afford their copay for their CGM supplies, they can call them, ask for assistance, and they'll lower their copay to an affordable amount.
Hey, that's great
I
information.
just had a patient with Medicare, especially the Advantage plans. It's hard, but I just had a straight Medicare. And this gentleman was 80 years old. He had vision problems. He was not checking his blood sugar. And I was able, through ADS, get him covered. He's not on insulin, but I just wrote, on medical necessity because of his eyesight, how long he's been a diabetic for 30 plus years. And he was taking 3 oral medications without insulin, and I just got it covered, which is the first time ever. So I don't know if any of you have had that blessing and luck that I had just the other day.
Yeah, absolutely. I have. I've also gotten them covered for dementia patients so that their family can remote monitor them.
I've had that for Parkinson's patients as well. I've had one of them that haven't been able to poke their fingers. So,
as a follow-up, and this is not necessarily directly related to any of these questions, but it sounds like there's quite a few, and there's a question alluding to this in a bit as well. But you mentioned for some of the patients who may be visually impaired, is there a CGM preference that you're finding that patients seem to do well with, or hearing impaired as well?
I like the Dexcom for that, simply because they don't have to remember to scan. They don't have to find the app and open the app and scan and all of that. They literally can just open the app, make the screen as big as they need it to see the number at any time.
Okay, great. Well, let's see. Let's go ahead and move on to the next question, Jake.
Sorry, before we move on, I just wanted to add one other thing that I just remembered. I also try to explain to patients like insurance coverage and affordability are not always the same thing. And I've had a lot of patients come back and say, well, oh, Medicare didn't cover it when they meet all the criteria. And I found out it's actually not that they don't cover it. It's just that the copay is still, more than was affordable. And we're still kind of working through some of those issues. So that was just another kind of thing that I think is really important for patients to understand. Covered does not.
That's a really, really great point. And I find that a lot too. And I think it's very confusing in Medicare when the copays are changing throughout the year as well. And I think on the first resource that Jake pointed out for the MCT2D, it has kind of a nice listing of what all the different definitions are for coinsurance versus copay versus deductible. And that may be a nice tool for patients to have in the future. Okay.
Also, can you hear me? This is Mary Wilson. I'm one of the panelists. There seems to be some issue, but I have a hoarse voice. For our patients who have high deductibles, we find going through pharmacy is immensely cheaper. So if somebody has a high deductible, putting them or a DME percentage payment. So I always start with pharmacy because the difference for one patient was starting out at like, $240 versus $40 as a pharmacy benefit. So I always start there. And then if it's not affordable, I tell them to get back to me and we try DME. So that's been we've kind of just unwittingly fell into that and saved somebody a lot of out of pocket. But for the last 2 years, we hadn't been doing that and they were out a lot of money.
Wow, that's a huge difference. Thank
you.
The
same with insulin pumps. Yep. So it's the same thing.
Thank you. That's excellent information. Okay. All right, let's move on to the next one. So this is getting a little bit more into the CGM reports themselves. What components of the CGM report are most commonly used in clinical decision making?
I mostly use average sugar, time and range, and the GMI. When I'm teaching patients, like these are your targets. But then the daily log is really great for lifestyle change. So I have them food log at the same time as wearing this. And then we really sit down and try to figure out what foods are triggering high sugars, especially with the type 2s that are not on insulin, because lifestyle change can really prevent their, from ever needing insulin.
Yeah. So I definitely utilize the daily log quite a bit. I also, first thing I typically gravitate towards is the percent the CGM's active, just to see how often patients are scanning, because that kind of helps me determine, how clinically accurate maybe those percentages are for patients. So that's usually the first thing I look at. And then I gravitate to the hypoglycemia section. And if that's, depending what that is, that's the first place I like to make interventions on, is that hypoglycemia number. And then looking at the time and target, and kind of like Susan said, I like to look at that daily log. And if a patient has had like a really great day where they're mostly between that 70 to 180 target, I talk to them about, what did you do during this day? Because you killed it. You did great. So just seeing what changes we can make moving forward. And then also utilizing that to see if there's spikes throughout the day, so we can, like Susan said, make those dietary interventions at that point. So, yeah.
And to add on, everything that they've all said is exactly what we look at, but we also try to find the one time in the day where they spike higher, and it's usually a pattern. And for some people, it's late in the night. Other people, it's dinner or lunch. So even with that, we had a lady come in today, and she was always over 300 at lunchtime. Well, there you go. So doctor actually changed her pattern and her base on what she's getting at lunchtime. So the daily pattern is big, but I also too look at how often are they checking, because if they're not utilizing it, if that monitor is not active, it's not doing its job, and they're not using it to its full benefit.
Absolutely, and I definitely find that that's still kind of a downside of using the Libre sensors compared to the Dexcom. And then can you speak a little bit to, because you get these CGM reports and they can be quite lengthy, if you're getting 14 or 30 days of downloading. And how much time are you spending during a clinical encounter looking at these CGM reports?
I'll go on that one. I usually will pull up their report at the start of my appointment with them, and I'll use mostly the summary screen to show the patient how they're doing. And then I'll kind of flip through that daily log to see where the problem areas had been with like lows and spikes. So I probably haven't opened the whole time that I'm talking to them, but maybe like 5 or 10 minutes where I'm really intensely thinking about that part. And then the rest of the appointment is checking in with them about diet changes, lifestyle changes in general, if they felt like they've had more lows or less lows and what's showing up, doing additional education about the device, and then making decisions about medication changes. So I'd say probably 5 or 10 minutes during the appointment. I usually have people slotted for 30-minute appointments for follow-up.
Okay. And I think we missed a little bit earlier in this, but if anyone wants to speak to kind of like the CGM workflow processes that happen, like how does the CGM report end up in your hands for that clinical encounter, that would be great.
I can speak to that. This is Mary Wilson. One of the ways that it can be done is what happens for me is my MMA looks ahead. I'm a nurse practitioner, and she goes to the cloud because she has shared accounts with patients through Diabetes Ed and now through all of our practices at Metro UMH West. And she can just upload it prior to the appointment. The other is if the patient has a device, then she can cord in and download it. We're working on getting 2 computers that are security okay for certain trained individuals to plug into that and to be able to download the Dexcom and the Libre readers. So that's been important as well. So then it gets up, so then it's available in scans. And once I put the scan in, I either use a snippet tool or a PDF. And I'm in Epic, but lots of people can use snippet or a PDF. And I actually copy that first page and I import it. So I'm not typing what percent they're in range, et cetera, but I still get rapid documentation credit for the billing code. So that's been a game changer in terms of time spent to document what we're doing and to bill it. And I bill it within my patient care visits, and it's probably, but it's not time-based. If I'm doing a time-based code, I actually have a phrase that says CGMS done separately, not included in time-based code of visit, so I don't get busted on an audit. I do it as video visits for the same thing. And then thirdly, I'll do it as just a provider interpretation and either do a call to the patient or ask diabetes ed, which I have as part of my team, to get back to somebody specifically on changes, or use something like a MyChart app, or say, hey, you need a visit. This is too complicated to do remotely to recommend changes. So those are kind of my three ways that I capture it. And anytime diabetes education sees them and downloads a device, I bill, I get it, and I bill a physician interp, which I then send to them. So, but we only do it once a month, but we capture a lot of those and actually have the workflow. We're working on doing that for the whole organization. But I get all the CGMs for our practice at Cedar Springs now. And so we're capturing, similar to capturing every EKG you do in billing, we're capturing that under the 952.
Is it 51?
I have 95250S for provider interpretation. That's for APPs and PAs. I think the 51 is for diabetes ed. And it's a very different term.
95251 is for the CGM interpretation, and the 95250 is for the procedure itself.
Oh, okay. Thank you for clarifying that. So I kind of skipped ahead. That was another question too. Did that make sense?
No, that's great. That's great. So you're getting all of the CGMs captured.
Like we are trying.
That's amazing.
We looked and realized we were not capturing 90% of this. We tried to do this like 8 years ago when I first joined this practice. I had come from a specialty practice, and I'm like, dudes, we're leaving all this on the table. And we did a lot of professional CGMs more then. And so we tried to do it, but it was complicated because we hadn't figured out the PDF. And I just learned about the snippet tool. It's all kind of tribal knowledge. So this group is great because we can share. And I actually have a dot phrase that I can send something similar. It still needs cleanup to the group if people want to see that eventually. And we're looking on a whole flow process at Metro, UMH West, to try to capture those. It really pushes your RVUs up too.
Oh yeah, absolutely. It's a lot of revenue on the table.
Right. Sure. And it improves care.
Absolutely, absolutely. And it's also nice to have patients putting in, if they're putting in the work, that we're looking at it.
Yeah, it really matters to my patients. When I see them in office, I'll often say, hey, we made some changes. You don't really have to come into the office. Do you want to do a video visit and talk? Or do you want to just upload in a month and I'll look? Because I don't, I'm not stalking them. But so then we'll put them on my schedule in like 4.5 weeks is a CGM interp. And that'll cue us to pull the data in and to arrive them. And then I do the workload. And then again, you might still need to see me virtually, or we'll give you a call, or I'll just send you a text and say, no need to do anything. You're doing great.
That's wonderful. That's wonderful. Can anyone else speak to like the process that happens in their own clinic as well?
Yeah, ours is a little bit different. We use Athena. And so when I set up a patient on a CGM, I have like both the dashboard for the Freestyle and the Dexcom. And so I just make sure that they are set up with those dashboards. And then I just download the PDFs that the dashboard generates, and I upload it into Athena as like an ad document. So if anybody else are Athena users, that's usually how I do it. And I just kind of put in a label like blood glucose log, but all that like other like ways to kind of navigate the billing is great. So we don't do all that.
It's nice that it's there for everyone to see in the EMR. Well, should we go on to the next question, Jake? Okay, this is a great question. It's something that we haven't brought up. But do most of the patients in your clinics, are they wearing CGMs continuously, or are they using them intermittently? Or what's kind of the most popular mechanism?
So for us, sorry, Mary, did you want to go first?
No, you can go.
I was just going to say, like, for us, we have both. Most of our patients use them indefinitely, but I will always encourage patients who are interested, especially if like cost is a factor, even just to do, a couple of weeks or a month, just to see what kind of information they get. A lot of times they find that it really helps them. And so they stick to it a little bit longer, but most of our patients are doing it indefinitely.
For us, many patients are doing it indefinitely, but we do a lot of, and we're not using the professional, but we just put them on patients. We have lots of folks who don't have the means or whatever. They're not going to scan it all the time. So we'll put a temporary one on them. We use samples or we'll use the professional, but we like using the samples because they can see the data. And our diabetes educators will slap one on them when they're in the office with me. And then 10 to 14 days later, we'll get it to really look at defects. So we use a combination. I think the diabetes educator in my office, I have 4 days a week because I've got pretty much all diabetes in my practice. But all of them know if you're seeing one of my patients, you better be putting one of these bad boys on most of the time, because it's the game changer in all this. And then a lot of folks come back and say, hey, now I want to do this. So we're a mixture.
I have a patient that he had an A1C of over 10, and it was not going to be covered. Taking metformin, would not take insulin. We put on a CGM on him. Make a long story short, he loved it. About 2 months later, he comes back and he said, I've got to have this. I can't live without it. So he pays for it out of the pocket. Cost him about, I think at Sam's Club, about $80. It's Freestyle Libre 2. And now we've got him, it's been like 6 months. He's doing really well. His A1C is 7.4, I believe. Now we're weaning him off of it. So he's going to do 2 weeks on, and then 2 weeks off, and then 2 weeks on, and then he's going to come see me after that 6 weeks. We're going to look at what we have, and then he's just going to wean himself off. I think, honestly, he's going to be more like a week on, 2 weeks off, a week on, 2 weeks off. But life is good. And like I said, he's not even taking insulin, but it's what's keeping him from cheating and eating candy and eating things, and he likes it. So that's what we do, and he's paying for it out of the pocket. I mean, he stopped smoking. That's a good thing. So
that's good. I don't know if we have CGM data helping with smoking cessation, but I'm here for it. Whatever benefits we can get. Absolutely, there's huge dietary adjustments. I talk to my patients and I say sometimes it's like getting a report card all the time, and there's definitely pluses and minuses to that. But for the most part, I think it's very, very, very helpful for most patients. All right. Well, Jake, do you want to move us on to the next question? We've got a couple of other topics coming up here that I'm excited to talk about. So we talked about this already in some respect, but what are the typical reasons for the patients in your clinics to be on CGM? Is it more because of the invasiveness of finger stick glucose checks? Is it insulin or medication titration, dietary intervention? Can you speak a little bit more to that?
Yeah. So I would say for me, the patients that I see, a big reason for using CGM are for finger pokes. Patients don't like poking their fingers. So if patients are going to come to me and they'll bring this up of, hey, I hate poking my fingers. Like, can I try CGM? I saw it on TV. So I would say that's a big majority of patients, but also I'll get some that are just very motivated and their friends have them or family members have them, and they've made such a big impact in their life. So they ask about those as well. So I kind of get a mix of patients asking me about CGM and if that'd be right for them, but also I guess if I'm actively seeking out, potentially looking into this for a patient, I would say it's more of patients that if they're having a lot of hypoglycemia, not really knowing what's going on, why they're having it, I like to put patients on a CGM, or if they're on multiple doses of insulin per day, I like to, I think this is just perfect for that as well, to see when we can adjust and when they're spiking throughout the day. And then, yeah, for dietary interventions for sure. And I think someone mentioned earlier, but I would say majority of my patients, over 90% of them, once they're on it, for whatever reason, they were decided to be put on it, they love it. And it's, yeah, kind of, if I can get a patient on it, then I'm going to try. So, yep.
And we think every diabetic deserves a continuous glucose monitor. So we offer them to every single patient with a diagnosis of diabetes. We even offer them to people with pre-diabetes where their A1C is rising. So the next check, they're probably going to be diabetic, just to see if we can, maybe make those lifestyle interventions. And a lot of times it's not covered by insurance, but it's a $75. The Freestyle Libre is $75 if you're using your phone. So, I mean, we try to talk everybody into it. I would say definitely if you're on insulin in our practice, we have talked you into it and you're wearing one, but we love everyone to have it. And then we have a fair amount of elderly patients here as well. So if we have concerned children, the Dexcom is amazing. You can just check in on mom or dad very easily. So.
Absolutely. And I think one of the features that I love in my practice, I see primarily folks who are on insulin requiring diabetes, and the ability to put in either carbs or insulin doses into the CGM app or receiver and look at how the doses are like how that affects your blood sugar in real time is just huge for both as a clinician and as a patient. Do you have just on the follow-up, Susan, with the pre-diabetes patients, do you have a set kind of program for patients who have pre-diabetes who are going on CGM for a follow-up visit?
Yeah, absolutely. So my role here is to teach self-management of disease, all chronic diseases, right? So diabetes is one of them. I typically meet with someone for 60 or 90 minutes to talk about their disease process. If we start a CGM, they're coming back in 2 weeks for data interpretation and education. That could be another 60 to 90 minute appointment. And then the appointments get shorter as they learn self-management. And hopefully with the goal that they're going to be able to interpret this data on their own, and they know what lifestyle changes to make if they see something kind of going south. Does that answer your question?
Yeah, that's excellent. That's a wonderful program. Well, thank you. This is great. So let's move on to the next question. Jake. All right.
I missed if we had gone, I had trouble connecting. I missed if we had gone over the special needs population.
We're
that-
just getting into that now.
Oh,
like
okay.
a great segue.
Great.
Thank you, Mary. So speaking of that, so I have Jake just pulled up this slide, and so the question that was asked was, how do you help people with poor health literacy or disability that impacts their ability to learn a new technology? And Mary, if you have any words of wisdom on that, that would be excellent.
We have our diabetes educators, of course, but also the wonderful thing about these is that folks, if they have a support person, there's the share, so they can share their data. So I have some folks who are on shared CGMs, and their support person can go, hey, you forgot to, to take that snack, or one of my very confused elderly persons, he would always know she was getting up at night and eating because she'd walk away and leave the reader, and it would alert she was out of range. So we used to laugh. So he'd run after her with an insulin syringe, and and she could eat her bag of Oreos or whatever. She was at end of life, but this was quality issues. She felt awful at 300s, and she had night issues, with her confusion. So we used a CGM just for quality of life with her. It, just to keep her in a safe zone as she transitioned to dying, and with her other diseases. But for special needs, I find so many of them do really well. Occasionally, all the alerts and alarms confuse them. So we only keep on really the imperative ones they have to act on, or every time it beeps, they're eating, they're afraid of a low, or every time it beeps, they're taking insulin, whether it's low or high. So it's really important to individualize how you use it safely with them.
Absolutely.
And I would add that usually for these people, I try to break down the education sessions in small chunks, include family members whenever possible, because I think it helps to have multiple people hearing some of that information, because we're not there once they're trying to do this on their own. And then just various tools and pictures. I think again, the collaborative has set up really nice diagrams and things to help patients with the just getting it on, and what's the best way to do that, and using those tools at the same time and really kind of small chunks has worked well for us.
Yeah, and in addition,
yes,
in addition to all those things, I would say one of the biggest barriers I've found with patients with their, if they have poor health literacy, is just getting them set up initially. So creating an account or anything like that is difficult, with sharing data. So if they have a compatible cell phone, when I'm in when they're in the office, I try to set all that up the first day, so that way they can share all the data right away. Because I've had it before where I haven't done that, and then trying to do it over the phone is a mess. So I just try to get that all set up, and I think that really helps. And for Libre 2, setting up alarms on the app helps with scanning. Hopefully that'll get better with the Libre 3 and the Dexcom, but those are, I guess, some of the things that I've noticed have helped.
That's a really great point, Juan. We found those lessons out, I think, early in the pandemic, when we're rapidly switched to telemedicine, and then we had, no downloads at all, because it turns out, that initial navigating of the apps and uploading, it's not intuitive, even if you're fairly health literate sometimes. And so that's a really good point. Anyone else have any great suggestions? Well, Jake, you want to move on to the next question? Okay. what are the best places to order CGM supplies for Medicare and Medicaid patients, and best places for other insurance? And we've had a couple of DME options and pharmacy options relayed. We haven't talked as much about the Medicaid process. If anyone has any specific guidance on that.
I have had lots of trouble with Medicaid. Meridian Medicaid, not so much. It's been very good. Molina, I'm starting to get coverage. What I do with Molina is I go right out and I get a prior auth. And I try to do that first. I use ADS for almost everything. Their advanced diabetic supply. I would say find out who your rep is, even with J&B. Find out who your representative is, who you can talk to. Because as soon as I've gotten their names, they get things moving. As soon as I send a referral, they know about it. So, and I use Parachute for ADS. But for Medicaid, I'm still struggling really hard with Molina. But I've been able to get two. So hopefully I'm hoping to glean some information today myself on getting more Molina Medicaid covered.
Medicaid has definitely been really tricky. We have not gotten consistent feedback about coverage for the patients who have type 2 diabetes with the CGMs. Like I said earlier, I usually send them to Healthy Living Pharmacy. I don't have luck with Medicaid at any of the local pharmacies with having them get that done. So, and then sometimes the Meridian, in terms of places to send it, the advanced diabetes supply seems to be pretty reliable with that one too. But my knee-jerk reaction with pretty much any Medicaid is to send them to Healthy Living Pharmacy.
Healthy Living and Solera merged recently, if you guys don't know that. So you can actually send them to Solera through Parachute for these Medicaid patients. And if it needs to go through Healthy Living, they'll take care of transferring that order over to Healthy Living.
That's very helpful. That's very helpful. Thank you. I knew that Solera had merged. I didn't realize it had merged with Healthy Living. All right, let's spend the last couple of minutes here talking about the next question, which is actually let's go to the follow up to that, Jake, if you don't mind. Even the billing, yeah. Can you speak to how you bill for CGMs and share insights about billing, and then we'll move on to some of the live questions so we don't forget about those.
I think Mary gave a pretty good summary early on for like ideal ways to get the prescribers to do it. As a pharmacist, I'm talking to these people all the time, but all that I'm able to bill for is the placement, and then I have to attach that for 72 hours of data to my note in order to get paid for that. So as far as interpretation, we've been told that even though we're doing it, we're not going to get paid for it as pharmacists. So what I've done is I've given doctors the access so they can log in and take the screenshots like Mary was talking about to plug into their note. And I made a smart phrase that they can use too if they just want to type out those numbers. But as far as I can do placement, but I can't do the ongoing billing. And even trying to get like the reports to the doctors before they see the patients in the office is difficult because I'm spread over too many offices. I'm not likely to be in the same office the same day that one of the patients I'm working with comes in to see their primary care doctor.
Jessica, you might consider doing what our diabetes educators do, sending them your note with the attached report, and then they could capture the interp.
I was told that I can't do it unless I send the report before I see the patient to the doctor, and then the doctor has to put in the note themselves to say what they want to be done before I call the patient. And then I'd have to give them the instructions from the doctor. And it's kind of self-defeating working under a collaborative practice agreement. So I know I tried to figure out every way that we could do it, but I've been told no with every question and idea I come up with. So
I wonder, we're looking into that as well at UMH West. Corey Lawrence, our director of pharmacies, And I wonder, because we already have the situation where we have the diabetes educators send us a note and we do it after the fact, not during or before. So
Yeah.
if I find anything different, I'll let the collaborative know. But it's a hard answer to get from anybody.
We're doing it that same way as well. We get our diabetes educators send it to us afterwards, and we put in the billing code. And
Have you tried that with the pharmacist? I don't see why it wouldn't be why it would be any different.
I don't see why it would be any different either, but
I don't
actually
think we're
have
doing
one of
that
the
at Bronson, though. It all comes down to how the individual institution's going to interpret the way that the billing codes are set up and should be
Oh.
executed.
Yeah.
So I don't know if you know, Susan, if at Bronson that if they're sending the endocrinologist, the diabetes education notes over to the primary care doctors, I don't see it at my offices that they're dropping these codes.
No, they're not, but I know that
Yeah.
they're looking at it, and they're working on a process to figure it out right now. So it's coming.
Jesse,
And
this is Heidi Dees. I just want to let you know, at Michigan Medicine with the primary care PharmDs, we were told that we couldn't, but there has been a very recent development in that. So more to come, and I will certainly share that as I dive in more. But it seems like we've finally had a breakthrough with people looking at codes as to what we can do. So we're trying to figure out a process. So I will certainly share that once we're able to figure that process out. And I might lean on Mary at a future date to inquire about your processes.
Yes, please do.
Yeah, it sounds like Bronson is in that same kind of step there. And then for the provider billing, we just trained all of our MAs on how to pull these reports for diabetic patients, and they pull them right before the provider goes in, so they can bill.
We have that as well in our clinic. All of our MAs do that. And then we have a template for CGM billing that has all the components that we need for billing of the 95251 billing code. And then we also have an order set that automatically puts in the 25 modifier, which has also been very helpful.
So you bill the 251 and use a modifier?
Mm-hmm.
Oh, we don't do that. As part of the visit, we just bill the code for interpretation and then also do the visit.
Yeah, our order set does both. It puts in the 25 modifier and it bills the 95251.
Well, that would push it up even further. Okay, thanks.
Let's maybe head over in the last few minutes to some of the questions in the Q&A. Let's see here. It's hard to see which ones went first. All right. So how often do we find that we need to write an appeal for a CGM?
Not all that often, maybe once every couple of months that I run into it where I'm writing an appeal. Usually when I'm trying to get switched from like someone who was approved for a Libre over to a Dexcom because they're having problems with the Libre and they wanted to try something else.
I usually write them when I have a patient that needs it but wouldn't traditionally qualify. So no insulin, but they have memory issues or whatever. Those are almost always an appeal, but almost always get approved.
I was going to say the same thing. My special needs patients.
That's the same thing here too.
And let's see here. Would anyone be willing to share an example of their order set at a future meeting? I think that's a great idea. Maybe you can have another meeting where we kind of talk about all the different order sets and what is helpful. We've talked about a few of them here today. Is the order set surely that you have one and all? Meaning, is it the same one that's used if CGM is going to pharmacy versus a DME?
The pharmacy and the DME are totally different because I will send things to J&B. I used to use it, but they didn't want the orders. They wanted it on their form. So now J&B, I will send over an order for it and they'll send me their order form that they want me to fill it out in. So it's not all in one, but the order set, it's all inclusive. It should be, but it's not enough. They want it on their form. I'm not sure if I answered that.
J&B will send you personalized order forms for your office if you ask them. And then you don't have to,
Okay.
it gives you that one touch with them.
One good thing is I try not, it sounds terrible, but I try not to use J&B once I got Parachute because ADS and Solera are so good. But sometimes you have to use J&B.
For our Blue Cross people, hear this well. J&B makes it so horribly challenging. I don't know why you still use them. It really, I can't tell you the hours wasted and the interruption in care that occurs as a result of their inability to process or explain, even though we do this every single day, always.
Yes, we continue to have challenges with J&B as well.
We used to have to wait 2 months and I'd call weekly. It's not like that anymore. And of course, I've got that rep. So as soon as I hit fax, she knows about it. Her name's Mary Story. I don't know if that would benefit anybody here, but my Freestyle Libre rep gave me her phone number, and it's been a lifesaver.
Wonderful. That's having someone who can directly help you is huge.
But it's absurd that every single group needs to sort out the tribal knowledge to get somebody a medically necessary item.
I agree. Absolutely, I agree. Well, we touched on this next question a little bit, more info about ADS. Perhaps we can mail some information out, Jackie or Jake. And then which CGM or pump do you recommend for patients with advanced vision impairments? We talked about the CGM a little bit. Pumps are kind of a little bit of a separate issue. But I can speak to that as well. Just in terms of if we're talking more of some of the hybrid closed loop pumps right now, I think that by far and away, the tandem with Control IQ or Basal IQ is much easier to navigate than some of the Medtronic pumps. And I haven't had a ton of experience yet with the Omnipod 5, so that kind of remains to be seen. But I have several patients with vision impairments on the tandem with Control IQ, and it's a very easy system to navigate.
And tandem screen is easier to read, whatever the lighting is. I don't know if any of the pumps have a like enhanced size for the really low vision people, but I have folks who use their magnifier to see the screen.
Yeah, that's what all of my patients do as well.
Yeah. I haven't compared. Our folks are loving the Dash, the Omnipod 5, but I have not looked at it from a low vision standpoint.
Yeah, I've been recommending mostly the tandem just because of, just like you said, the backlit screen is it's just so much easier to see and with fewer calibrations. Sounds like we need to have a session on optimal billing at some point for CGM. And then can anyone speak to pulling in CGM data into eClinicalWorks?
It looks like that was answered live, Dr. Mizukami style, by Juan, who said that they use eClinicalWorks. They upload it similar to Nadia's workflow in Athena, where it's attached as a PDF within the progress note. So for example, download the review from Libre View or Dexcom Clarity and upload the PDF as a document in eClinicalWorks.
Thank you, Jackie. And another question about billing. And has anyone had success getting CGMs covered for Priority Health Medicaid?
I think that's another one that Medicaid's just so picky that, especially the Priority Health one, they really need to be on like 3 doses of insulin a day in order to try and get it to go through. And even still, I think the one Priority Health Medicaid patient that I'm thinking of, I couldn't get it even though she is on multiple doses. and she has issues with, she's got a lot of neuropathy in her hands and arms, and she won't do blood sugar checks in any other alternative places that I've suggested. So I've just been doing samples for her whenever she comes in. I try to give her a couple more and have her keep coming back in. So I've been stuck on that one too.
Yeah, those are tough cases. We've struggled with Medicaid too. I know that there's large efforts going on at a national level to try and improve access in Michigan Medicaid. So hopefully progress on that in the near future. Well, it's past 1, so I want to be cognizant of our panelists' time. Really, really appreciate it. So much great information here. And I think we'll wrap up, but we'll certainly have more information. It seems like it's a very active topic.
Thank you, everyone, especially to our panelists. We really appreciate your time today. This was a fantastic discussion. Thanks for everybody that was able to attend. This was a very robust conversation. We're so grateful for all of you. Kara, thank you so much for leading. And we will consider having more of these in the future because, again, as Dr. Mizukami said, it's a very active discussion and continues to evolve as we grow. Have a great rest of your day, everyone.
Thank you.
Thank you.
Thank you.
We'll post this recording for everyone as well.
Thank you.